Oh, now we do. Okay, good morning, everybody. Welcome. Today is October 27th. It is 9:52 a.m. We're convening for a work session on the Complex Behavioral Health Needs Community Task Force Recommendations Final Report submitted to the Assembly September 5th, 2023. We'll do introductions in the room. Mr. Martinez.
George Martinez.
Zach Johnson.
Karen Bronga.
Scott Myers.
Christopher Constant.
Felix Rivera.
Thea Agnew-Benben.
All right, thank you. And we have a couple members of the public in the room, Clerk Matthew Hurt, attorney, and Mr. Rivera.
Great. Thank you, Mr. Chair, and thanks to the members and for Thea for making time for this today. I know we have a long day of meetings ahead. So earlier this year, in about March, April timeframe, the idea for this task force, the Complex Behavioral Health Needs Community Task Force, came to be. It was actually an idea that came from the Fairview Community Council and eventually morphed into this specific task force. And it was all centered around how we can better help with the demobilization of emergency cold weather shelter in April. And one of the things that we knew going into that demobilization was that there would likely to be increased behavioral health needs in our community. So this task force was formed to help address, both from the short-term perspective as well as the long-term perspective, how we can mitigate those behavioral health needs in our community. So this is the second and final report that the Complex Behavioral Health Needs Community Task Force came out with in September. And I wanted to give an opportunity for the full assembly through a work session to hear about this report. And really the main architect of this report being Thea, to walk through the recommendations. But we also, if folks want to turn to, forget where it is, it's page 43 of the report. You'll see, that's the Leadership Summit, folks. It's page 40 and 41. You'll see the long list of folks who really helped to come up with the recommendations. And then eventually on page 43 of the report, you'll see the Leadership Summit participants. So we had really strong leadership from a variety of different organizations, state level, local level, that helped to continue to flesh out the primary recommendations and really commit to working on these issues. So with that, I will turn it over to Thea, who can walk us through the report and walk us through some of the recommendations.
Great. Thank you. Thanks. Oops. Sorry.
Switch mics. Actually, some of them have that weird effect. Just there's plenty of other mics. Thanks.
That's better. Thank you. Okay, I'm going to go through these fairly quickly because we don't have that much time and it'd be great to have more time for discussion. So let's just dive in if that's okay. Who's doing the slides? Jasmine? Okay. So I think Felix already shared the context. You can keep going. So just a quick reminder of the goal. We were tasked with identifying optimal solutions to address complex behavioral health needs of individuals experiencing or at risk of homelessness, and consider both immediate term and longer term solutions. And I just want to hone in for a second on this. I think the thing that's important to remember is that this need emerged, as Felix said, from concerns around people experiencing homelessness. But the group of people that we're concerned with this report and this task force are people with very severe and untreated healthcare needs. So I think it's really important to focus in on this as a healthcare issue. And those healthcare needs that are untreated often result in people not being able to secure and maintain housing, which then makes the experience of their untreated healthcare needs a sort of public situation. Whereas you can imagine somebody who has untreated diabetes, for example, could just be in their home with that situation. Oftentimes with people with behavioral health needs, if they go untreated, they can't secure and maintain housing. So it becomes a more public situation. So just want to focus in that this task force is primarily interested in people with a healthcare need. And the housing piece is part of that, but the healthcare is kind of the central piece. Okay, let's keep going. So I won't go into the process. We had a number of meetings. We had a leadership summit. We had a lot of back and forth with our task force. And the task force also had the opportunity to answer a survey, which Claire and her staff distributed so that we could make sure that people were supportive of how we prioritize the recommendations in the final report. So you can keep going through this. And the next one, I think, too, Jasmine. Great. Okay, so we did start with a theory of change, and we adapted this from one that was developed, I want to say December of 2021, by the group of providers that had come together to meet healthcare and social support needs at the Sullivan. So when the Sullivan was first stood up, we actually had a health clinic operating there. We had behavioral health services on site. We had a lot of social services providers also bringing their services to the Sullivan. So that group had been meeting for about 6 months, and I was helping facilitate that process. And we'd come up with a theory of change. So it was kind of a handy starting place for this process. So we basically started with that and kind of reviewed and revised it with this current task force. So we came up with the long-term outcome for this process that people with complex behavioral health conditions who are experiencing or are at risk of homelessness achieve whole person health and well-being. So that's really trying to address physical needs, behavioral needs, community and social supports, housing, the whole package. But in order to get us there, the three short and medium-term outcomes that we identified is first that we increase the number of people who are engaged in comprehensive primary and behavioral health care. And for those of you that don't know, that's a very constrained resource in our community. It's extremely difficult, especially if your payer source is Medicaid and you're not a tribal health beneficiary. It's very difficult to get primary care and outpatient behavioral health services. So that's a really important outcome that we identified.
Just briefly, not Mr. Bond has arrived. It's 9:59.
The second outcome is to decrease the number of people who are experiencing unsheltered homelessness. And that requires increasing the use of emergency shelter, exits to housing, and retention of housing. And the reason that that's such an important outcome is that when someone has untreated behavioral health needs and they're experiencing unsheltered or any kind of homelessness, it makes it incredibly difficult to treat the primary need. So by just decreasing their homelessness, even if that means, being in a shelter for a period of time and getting a stable place, you can then start to actually treat the needs that are the primary causes of the issues. So that's our second one. And then the third one is that by doing that, you really do increase the cost effectiveness of community resources because you're helping people access lower cost healthcare and services. And so for the municipality, as you all know, a big proportion of what our EMS and police are responding to on a daily basis, is people with untreated behavioral health needs. So that's a very expensive resource, and it doesn't actually solve the problem. So, and APD and AFD will tell you that. Okay, keep going. So this is a continuum of care. This was not developed by this project, but I think it's just a helpful resource for you. This was developed, it's actually been iterated over multiple years, but this current incarnation came out of a project that the Mental Health Trust and the Department of Health and Family and Community Services supported this year that Agnew Beck worked on that is really related to people who are being detained or committed involuntarily for mental health treatment. And the big stakeholder group that came together for that project worked on this version of this continuum of care document that really tries to show what are all the things we need to have in place in our communities in order for people to really maintain their health and independence in the community. So that's what's in that big circle. And then as you go further to the right, that's when people have a kind of crisis and they escalate in their care needs. But the goal should always be to help people return back to that circle there. So that's a resource for you to use and think about to just kind of help you understand what does the full continuum look like. Okay, we can go on. So now just going just going straight to the task force recommendations, if you look in the report, we have 3 main goals and we have a whole lot of recommendations for each of the goals. And I just want to say that all of those recommendations are really important. So I think the plan provides a kind of almost like the starting for a work plan to really go after this issue and make huge amounts of progress. But in order for it to be kind of actionable, the task force decided to identify one priority objective for each goal. So these are like the things out of all the things that we identified for each goal, the priority objective is the one we feel like is like near term place to start, important action item. So the first goal is around really outreach and triage. So it's how do we identify people who are the most vulnerable and address their care needs. And the reason this is important is that people aren't always just like walking into their community behavioral health center and saying, hey, I need help, right? They're showing up, all the places that we see. So it's not enough to say, oh, we have this center here. Why is no one showing up? We actually have to go out and find people. So, but part of having that happen, because people show up in so many different places, is you really need to coordinate the system so that when somebody pops up somewhere, they actually get connected into the right place. And that's what's happening for the individual. But in order to do that requires this whole back end of coordination, which really doesn't exist very well for behavioral health, as I'm sure you're all aware. So here in Anchorage, we have lots of different ways of addressing this over the years. But I think one real opportunity is to think about how can the Anchorage Health Department be more engaged as a kind of backbone for this system in Anchorage. Because there's a lot of state resources, there's private and public resources, there's the need for data, there's the need for contracting. All that stuff could potentially be coordinated by a position or a team at the Anchorage Health Department. So that was our priority objective, and you can go to the next slide for kind of our rationale for that. That really, we need to increase partnership, we need to increase funding, we need to be able to strategically manage contracts and grants, to really, and then coordinate all of the parties, some of whom are municipal parties. So AFD, APD, they're really willing, excited partners in this process, as well as others. So that's our first goal and our priority objective for that goal. So let's go to the second goal. So the second goal is really so once you find somebody, where do they go? Because the folks that we're talking about are not the people who are easy to just get right into housing, right? This is when we had the Sullivan up and running. These are the folks in the warming shelter, or people who were even kicked out of the warming shelter. Before that, when we had Brother Francis and Beans, these were the folks in the sidewalk because they'd been trespassed from that campus, and APD is then interacting with them. So there's got to be a place that's appropriate and that works for the folks that we're trying to then provide more ongoing care to. And so our group talked about immediate, and we started off with very low barrier. We went down to no barrier shelter, which is hard to achieve. So that's maybe a little pie in the sky, but a safe year-round place where then people can get access to case management, access to healthcare, and then that's the stepping stone into more permanent housing. And that housing might look like assisted living. For some people, it might even be skilled nursing. For other folks, it might be supportive housing, permanent supportive housing, all the other options that we have. But there's got to be a landing place for people to start that process. So what we talked about were sites where we have a mix of individual shelters that could be like the pallet shelters that I know you've looked into. And then maybe some small group quarters, like a portable. The reason that that's important is that some individuals have behaviors and symptoms that mean that they really don't do well with other people. Other folks might do better with other people. So having that kind of mix of options at these shelter sites would be important. They also need to be safe, secure, and year-round so that there isn't like a time limit for people to get out. What we heard from a lot of the task force members who were providers who had been seeing folks at the Sullivan, but then when the Sullivan shut, those people all like scattered to the winds. And then they lost that daily connection with them that was actually helping that person remain stable. And then once people go off their medication or have other things happen to them, they end up in corrections or other places. So there's got to be a place where a person can build that trust. Sometimes these systems take a long time to apply for. To get onto a Medicaid waiver for assisted living or other home and community-based services, that can take 6 months. But guess what? Our municipal department, the Aging Disability Resource Center, is the center that does that. So if we can find a place for a person to be, for them to start working with the ADRC, they can start getting into that process. Otherwise, they're pretty much excluded. Let's go to the next. Okay, so the other thing that would be important about these sites is that there would have to be like a contracted healthcare or behavioral health or peer provider that would actually be managing the site. So it's being managed as a kind of, I don't want to, it is kind of shelter, but I don't really want to call it that. It's kind of it's a landing place and it's being managed by healthcare providers. So it's almost like a stabilization service.
I'm going to jump in there. You added an extra or, and it substantially changes the meaning. So sites managed by contracted healthcare and or behavioral health. You said or peer providers, but the report.
Yes, so
language there
behavioral
says-
health peer providers. Yeah.
Yeah, you added an or.
Sorry.
No, so but there are behavioral health providers out there, and so
Yes.
I wonder is that to exclude those individually?
No,
Okay.
I would consider them under healthcare. Yeah,
Okay,
yeah.
thank you.
Thanks for that clarification. Yeah. And then case management too. There's different levels of case management for different people with different needs, and those could be delivered. Again, that's where a behavioral health provider would really come in. So we were estimating, there's no like exact count of the folks that we're interested in with this project, but we were thinking maybe 50-person sites. I don't know. That's a guess. So, okay, we can keep going. I think I've shared all this. Okay, so third goal is kind of the next step. So you'll see the goals are really, the first one's outreach and triage. The second one is how do we help people kind of stabilize? And the third one is healthcare, care coordination, and housing. So that's as quickly as possible, helping people assess their needs, address their housing, behavioral health, medical, and longer term care needs. So again, our priority objective under this one, and again, there's a lot in here. So this is just the one that rose to the top, is that what would be helpful immediately is having contracts. And again, this could be something the health department does with behavioral health, clinical, and peer providers who can do mobile outreach and can provide that medical and behavioral health services. So that could be at these sites if they were set up, and also to people who are just in the community. And again, what we heard from a lot of the folks on the task force is they were doing this. We had a lot of engagement from providers who were literally going and finding their folks at Davis and giving them medication every day. So like really dedicated people trying to help people who are severely in need of assistance stabilize. And some of them were doing that without actually continuing to get paid after a while. So it was really dedicated people. So that service is really needed by some people in our community. And let's go to the next slide. Yeah, so I think I just shared this. Oh, and then I just want to add the last part of that. So Crisis Now, I'm heavily involved with that. I know you all are as well. That's a really awesome effort that's going on in our community, and it's been building over the last 4 years. We've got the mobile teams, we've got all the different pieces, we've got crisis centers hopefully opening next year. Those are all super important, and I think our task force acknowledges how important those are. But we know that there's a lot of work happening already. So we chose to prioritize things that were kind of complementary to that work, but we didn't prioritize that work with this report. So just wanted to tag that on. And I think that's the end. Yep. Okay. Done.
All right, thank you.
Yep.
Anyone want to jump in the queue? Mr. Martinez.
Thank you. Just a question for clarification. Do we have a sense of the percentage of what we call homeless that are fit into this category? Or some way to get a
Yeah,
sense?
I think the best way, I think we've tried that on different occasions. I mean, there's a few places we could go for that. So in the report, we do identify a couple of data tags that are in the homeless management information system. And so I think it's possible, we didn't do it for this, but I think it's possible that we could use those data elements to get a more up-to-date number. The Home for Good program that the Muni's participating in, back when that began, we did a feasibility study for it, and we basically cross-referenced 3 different data sources. And so I think they're still using that those 3 data sources to figure out who's eligible for that program. That would also be a good data set to use. And then there's the Coalition to End Homelessness has a like a case conferencing group that meets that focuses on people with very high needs. I think that's another group. That's another way we could get at that number. And then the fourth one is that the mobile intervention team at APD and AFD and some of the hospitals have a much more informal kind of case conferencing group that comes together that tries to address people who are very frequently showing up in those locations. And I think that's another place. So all to say, I don't have that number, but I feel like we could get it if we wanted it.
Thank you. Thank you.
Ms. Branca?
Do you, I was just wondering if you've ever outreached with UAA, like social services students or the nursing program to help with outreach. I know they always need hours for, and I don't even know, maybe you're already doing that, but just occurs to me that the outreach is pretty difficult because they're spread, people are spread everywhere. I biked in today. I know I'm not supposed to say anything about me, but there were 3 people rolled in a tarp along the trail. And it was heartbreaking. And I'm, is anyone going to check on them? Are they even alive? But I mean, there's an army of students at UAA, and I just would be cool to engage them.
So I jump in quickly and just say that Miss Agnew doesn't do outreach services. You aren't in direct service, I assume. And so that would be a question for various other entities, but the philosophical question of do we approach the university or other programs is a good one.
And I can speak a tiny bit to it. So in the past, Providence Family Medicine Residency has had a focus on street medicine. And they did used to have residents. These were residents trained to be physicians would go out with, I think, the Muni mobile intervention team. I think over changes in leadership, like that's not currently happening, but I think it could. I think same with nursing students, that totally could happen. The social work department at UAA has some really great leadership. Again, I think all those things are super possible. Right now, I think what the main outreach that's happening is the Anchorage Coalition to End Homelessness is organizing outreach teams. And so again, they could partner with those entities too. Yeah. I think it's always hard to fit. It sounds awesome. And then you're like trying to fit it in with your like training programs.
And I'd say the health department is also providing outreach. And I think probably every one of the organizations providing shelter is doing some limited outreach. Mm-hmm. And it's always interesting, the conversation about tapping into student resources, but students are students. Mm-hmm. They're not professionals. They're not paraprofessionals. They're not peers. And so there are some limitations. I think what works in my experience in the field is that those folks really are good at internships and connecting with folks and then learning how it works and then joining the workforce later, but they aren't the ones you would want to turn to depend on for the actual outreach work that you need to deliver today.
And I, on that note, I know the mobile intervention team at AFD right now has a student working with them. So I think you're absolutely right. Yeah.
Yeah, absolutely. It's tricky, like students, great, but limited.
Yep.
So Mr. Volland.
Thank you, Mr. Chair. So something that I am interested as we enter budget season in pursuing is that recommendation about healthcare providers being able to go out into the field, meet people where they're at, the opportunity to connect people, to get them to clinics as needed, but also to provide that care on site wherever those people may be. And I think that's one of the strongest recommendations of the report. And I know that there are entities that have been doing that, just sort of kind of ad hoc, like the Mountain View Health Clinic folks who participated in the task force. And for me, I think that there's opportunity to have them work cohesively with the MIT or the MCT. For me, I think the mobile crisis team under the fire department and MIT under the police department are both very capable. And we've had a lot of conversation about how we want to build them out more and have them have 24/7 operations. I think that's very valuable. I do think just the way that they're set up, though, is more in sort of that triage and then emergency response mode. And so if we were able to augment that with another group that was taking on the responsibility of, we're going to consistently check in with these patients, the patients who have been identified by MCT and MIT as needing more ongoing support. Help keep these people on their medications. Go out and do telehealth. I mean, there were groups that were going out with their iPads and working on site with folks. And so I think that building that out and almost kind of doing the model of what was the core team in times past, I think would be super valuable. So I'm hoping to meet with a couple different folks over the next couple of weeks, but I just kind of priming my colleagues maybe to be anticipating something to that effect going forward in terms of the budget. Thank you.
Yeah, I just want to add to that. So one of the things that was discussed a lot at the leadership summit, and is just a kind of just a sort of systems issue, is that right now the way behavioral health services have kind of migrated over the last 10, 20 years is like, we used to be totally grant funded. Then the state went through a process of really, and it's an ongoing process of trying to get behavioral health providers to transition more to Medicaid billing. And then you've all heard about the 1115. That's a set of services available through Medicaid. So all of that's awesome, but there's people who aren't eligible for Medicaid, and there's people who don't have any. Some people don't even know their name, right? So for the services that are like what Mr. Vollin's describing, those are still need to be considered kind of engagement services. And it's not easy to bill for those. So in Fairbanks, where the mobile crisis team is a behavioral health provider that's delivering it, not like here where it's a city agency, they're having a terrible time, even though you can bill for mobile intervention. They're having a terrible time doing it because it's like, how do you in that encounter get some, oh, can I also have your billing information? And, that's not super easy to do. So we talked about this at the leadership summit, and I think the state folks heard it. It was a little bit hard to know if it was really landing, but just that there's this real layer of care that really can't easily be billed for. But once you establish that relationship, then there are great 1115 services like intensive case management, like assertive community treatment, crisis interventions in our state plan. Like there are services that you can bill for, but it's once somebody's enrolled. And actually some of those you can do, before they have a treatment plan, which is a whole other hurdle with behavioral health. So anyway, it's that layer that I think where some additional funding that's more flexible could be. And the other thing too is even when you do bill for services, it doesn't necessarily cover the time for transportation between, or how do you find that person? You can only bill once you see them. What if they don't show up to your appointment? So the billing just has limitations. It's a good resource, but it can't be considered the only funding for this type of work.
And I just want to add on there a little bit before you go, Mr. Rivera, that there are also providers who aren't skilled to bill Medicaid. It's complex and has many legal ramifications. And so for upstart organizations, new organizations, peer organizations, it's scary what the federal government can do, or the state, with the Medicaid billable services. And I think that the problem as well that is going to confront that concept is something that I think the report already spoke about, and we're not there yet, and that's the continuity of location is going to be the key piece to any service like that being really workable, right? So if the idea is mobile, healthcare in the field, that you want to help provide them medication management, if they're moved next week to points unknown, the whole concept is evaporated for that individual. And that's the problem that people are kind of raising up right now as a whole in the field, like whether it's abatement or whatever reason. So then the second part of that, of course, is what it proposed, the smaller scale locations that are more permanent in nature, where an individual might spend some time. Then you have to manage the neighborhood impacts. And so it's a very complex scenario to get to where you're talking about. And so it's good to think deeply about what that money might do and how, because money is, when I get my chance to comment, the linchpin of this whole thing. Mr. Rivera.
Thank you, Mr. Chair. So I just wanted to recognize that I believe we do have some participants in the audience who are were task force members. So if you did participate in the task force in the audience, if you can just raise your hand, let us know. I know there's several of you here. Wonderful. Thank you for being here. Thea, could you talk a little bit about some of the implementation work that's going on. I know you and I had a meeting with Anchorage Health Department Director Kim Rash, if you can speak to that. And then I know we're also going to be having conversations with the trust on these issues, so if you can speak to some of that.
Yeah, we talked a bit with Director Rash. I had just done a little bit of research while we were putting the plan together, just looking at vacant positions at the health department and thinking about, is there already budget, assigned that could potentially be, leverage for this? And it turned out the positions that I had, thought were vacant were filled. So there were some preliminary conversations with Director Rash about potentially, orienting the work plan of those positions that could potentially assist with this. I think another piece of it is just like Member Constant just said, it's the money, not so much for those positions, but like bringing in additional funds to make this happen. And that is, that's an art in itself. It's a skill. There's federal money, there's state money, there's, the trust is a great resource. But we do need some place for it to be planned and coordinated and implemented in an effective way. So I don't know if that's what you wanted me to speak to.
No, thanks. I just wanted to make sure everyone was aware of some of that work happening. And then folks who are on the legislative committee have already seen some of these recommendations in here are part of the legislative committee or legislative program draft, because some of these things are really state level changes and state level investments that we need to ask that they really be a bigger part of the solution here. So, speaking of funding, right, it's all of it, the state, feds, trust, local funding, how we can braid it all together. So that is something, hopefully, when we get to the final legislative program, we'll maintain those strong requests to the state. That's it. Thanks.
Thanks. And I have myself in the queue that Ms. Brawley. And, many years ago now, this was pre-2020, 2019, when we had kind of the blow up at the state level of the funding for homelessness, and all of a sudden people camping everywhere that we've just been trying to manage ever since. I had proposed that the Muni should contemplate setting up what effectively this argues for, a behavioral health department at the Muni and the health department, an actual focal team that their job is behavioral health. And I was pilloried. It was not a welcome conversation. I was laughed out of the room. I received dozens of emails. And the primary argument at that time, which is not without merit or without reality, maybe not merit is the right word, but reality is the fact that the costs associated with all of this are extraordinary, like extraordinary costs. Setting up and operating behavioral healthcare it would put our health department probably beyond the scope of costs of our police department, which is over $100 million a year, to try to get ahead of all of this. And so I think that the key to making this work is figuring out what our role is, where we can have critical people doing critical work, but we have to have a partner in the state. The waiver has to provide services that are needed, and the grants have to fund the positions and the individuals who are in need of major healthcare, because behavioral healthcare is healthcare. Healthcare is the most expensive service other than jail or, those kind of things, and maybe sometimes more expensive than the jail intervention. It's a huge cost analysis that we would have to undertake to understand what this means. And so it doesn't mean I don't support the idea of moving us this way. I mentioned it in 2017 and 2018, but it's easy here. But when you start putting the spreadsheets behind it of the actual cost analysis, it becomes quite shocking. And so we are going to be dependent on the state and the feds.
I guess I see that just a little bit differently. So like with the current health department, there are some direct services delivered by the health department. Those, before the pandemic, I think there was an interest in kind of considering what the role of the health department really should be. And when you look at sort of the national best practice for public health, Public Health 3.0 talks about taking a population approach and really addressing like the full needs of the community, but maybe not so much through just direct care. And that's not, obviously the health department does a lot of things, but because there are a lot of places that do direct care, right? Neighborhood health. I mean, we're rich with organizations in a way, But I think what we know is that those organizations, and this is always the trick with homelessness, it requires this kind of intense amount of coordination to really solve the problem. And it also does require targeted additional funding. So I think like it's absolutely true that like our behavioral health organizations that exist aren't able to meet the need. I mean, even South Central Foundation that sat on the task force, they do intensive case management. They're not able to meet the needs of the folks that we're talking about. They were super clear about it. They're like, we don't have enough billing, like the billing doesn't pay for us to serve the folks who have the most intense needs. And so I think some of it is really more around how do we like coordinate what exists, increase capacity where it's needed through bringing in other funding and targeting it in the right place. You know, I always think about like the safety patrol. Like that's a pretty meaty contract. Obviously it's being redesigned right now, really does deliver a version of behavioral health care, although it does it in an emergency stabilization mode, right? So, and it's mobile, right? So is there a way, just like we've done with the fire department, could we add to that? Could we add a clinician to that? And I think some of this is actually in discussion already right now, but you know, is there a way, like once the crisis center comes online at Providence and South Central, do we still need the safety center? Like can we have that conversation at some point? And obviously you don't want to do these things super abruptly or anything, but like, how can we kind of take the resources that we have? You know, we have a clinic there, like, could we have a contract with a clinician to come, you know, to our, I don't know. I mean, I just think there's a lot of ways that the health department could be more of a coordinator and kind of capacity builder and bringing more funding in. So it doesn't have to deliver it directly, because you're absolutely right. Like, we're not going to meet that need, but could we like enhance and kind of knit together what we have?
Yeah, and I completely agree with that theory, and it's the only way. It's just the reality of what's missing. If you heard from South Central Foundation, who is under the BIA and tribal healthcare, and they get 8 to 10 times as much for a unit of service as a regular provider, depending on the service, the daily rates and whatnot. It's, if they can't make it pencil, then it's very, much more difficult conversation in a broader sense for how it's going to pencil. And so, again, all of this I think is preliminary and good. It's important. It's a fulfillment of what I think I asked for 3 years ago or 4 years ago, I beat up for, but, and I really appreciate it. I just, probably we need an economic analysis too, to go with it that like starts to paint the picture. And it's very interesting. So thank you.
I think of feasibility, like if we actually could get the number of folks we're talking about and start to nail it down. Yes, you're right. That's where it gets real.
Yeah. And then we can pick off specifically the elements that we can chew on and fund, which are within our mandates as government, then probably it's a good next step. Ms. Brawley.
Yeah, thank you. And apologize for being late. I heard most of the presentation. So building on Chris's comments, it is important to remember that we have health powers as a community. And just to give context, in other states, counties do have health powers and do things like public health, a lot of the functions you're describing, and even can run hospitals, or they contract to a private person to run that hospital. But it's all of that to say, it's not unusual for this conversation to be happening, but our particular context in Alaska and Anchorage is challenging, extra challenging, as Member Constanardi said. I also want to underscore the state responsibility piece. I am getting to a question also, but I want to underscore the state responsibility because I think we say that a lot, and people are used to hearing it, which is the state needs to do more. But it's not just a shifting of responsibility. It's literally that is part of the state's responsibility, and we and other communities are asking for that, and that there is a limit on what cities can do, especially with the systems we have, and funding is a huge one, and also just the general conversation about what is local government's responsibility versus other entities, state, private, all those things. So also where I'm going to is we started talking about tribal health. And I had a question about where tribal health can fit into this. Obviously they're providers. It is a portion of the population. I want to be really clear when I'm asking that I'm not saying that this is quote unquote, the Alaska Native Corporation's responsibility or the tribal health system's sole responsibility, because what we're talking about is an everyone responsibility. It's a public issue. It's a systems issue. But I am curious kind of where you see opportunities, and or maybe just talking about where the tribal system is already fitting into that and doing their part. I think that'd be a helpful part of the conversation.
Yeah, I think it's a great question. So, and South Central Foundation has a very robust set of services. So they, in partnership with ANTHC, as you know, run the Alaska Native Medical Center. And for that campus, they have what they call the Behavioral Health Urgent Response Team. It's a 24-hour a day team. So anytime someone goes to the emergency department or anywhere else on that campus and is having a behavioral health need, that needs met with that team. In addition to that, in their primary care setting, they have behavioral health integrated into the care. So anyone who's a beneficiary who's going there for primary care is also accessing their behavioral health services in that outpatient setting. In addition to that, they're very involved they have a very robust behavioral health department. They run numerous residential programs. They have a day program called Koyana House, which you may be aware of because it's right next to the old ANMC site. That is a day program for people with severe mental illness. It's actually open to non-beneficiaries as well. And their census kind of went down during the pandemic, but they're building it back up again. It's a great program. They also have plans for expanding it. They also have on-site medical care there as well. And then in terms of Crisis Now, really South Central Foundation has been a partner with the trust and with Providence going back probably 5 years, when the Department of Health started talking about Crisis Now. And so they've been in the planning stages for this whole period. Their plan right now has shifted a little bit, and it's actually, I think, in a way gotten better. They're now planning to have the site that's currently at Tudor and Elmore, which right now provides some of their withdrawal management programs, is going to be a new facility that will do crisis stabilization, crisis residential, and withdrawal management in one building. So they're actually expanding what they were planning on doing previously, which was going to be located in their emergency department and was just going to be a portion of that. So the timeline is now a couple of years for them to get that totally up and running, but that's going to be a massive game changer. And if Providence also manages to get their program going next year, which is their hope, I'll also have that 23-hour service and the crisis residential beds is what they have planned. That will greatly, that'll just be a massive increase in capacity for people to get stabilization. But then it does kind of lead to the next piece, which is, okay, where do people discharge to? What services are available in the community? And again, like what's happening in Matsu, which is pretty awesome, is they have this whole post-crisis network that they're organizing where they have all these outpatient providers, like almost 20 of them, like working together to figure out how to, who's got room for which client and which is appropriate and the whole bit. So, and again, in Matsu, they've got the Matsu Health Foundation that really helped do that work. We don't really have that entity here. And I think that's partly how this report kind of envisions the health department playing a little bit of that role, where you're able to kind of bolster and coordinate and convene and, see gaps, help meet them, bring new funding in, that type of work. I hope that answered your question, Anna.
Ms. Branca?
I was wondering, I know the Coalition to End Homelessness has some statistics up, but Mr. Myers and I, when we visited API, we were just gobstopped at the $2,500 a day to be an API, and then emergency room visits, the cost. Somehow we know the mobile stabilization, and we know that complex behavioral care is expensive, but if we could get the message to people that when you get to the end of the road, a API commitment or going to the ER over and over or to jail is way more expensive to our community than, going out and meeting their needs before they get to that level. I think, I don't know about George, but I hear a lot from people that just put them in jail, just commit them. And I think having really clear, this is the much more economical way to handle this situation in the more humane way.
Well, yeah, and I think it's important to acknowledge that people are already in jail. So, some estimates between 60 and 80% of people in corrections are trust beneficiaries. So people are already in jail. In fact, DOC is the largest provider of mental health services in our state. They have 200 beds.
And addiction treatment.
Yes, and addiction treatment. So, and if it were up to me, they'd be even more a provider of addiction treatment, because we did a study a couple of years ago that like probably 85 to 90% of people walking in the door at DOC facilities have some level of substance misuse issue. And it's only a very tiny proportion that really get assessment, and then a much smaller proportion get treatment. So, and then when you look at reasons for people returning from parole or probation, substance misuse is the highest reason that people return. So we're basically bringing people in the door with an issue that is untreated, not treating it, sending them back out, happens again, go back. So that's already happening. That's our solution right now. So it's expensive, and it doesn't solve the person's issue. It doesn't even give the opportunity to solve it in many cases. So I think you can answer that question is, yep, we're doing that. That's why API is always full. And there's plenty of people that need inpatient level of psychiatric treatment in our state who just don't get it. And all the other levels of care below that. So you can check that box, but the reality is that it's expensive, it doesn't meet people's needs, and it still creates the situation we see in our community of people suffering, and then residents seeing that and feeling like the world is ending, because how can we live in a place where people are wrapped in a tarp on the side of the bike trail?
So I put myself back in the queue. A couple things. I professionally work in this arena and have for 20 plus years. I'm not a clinician or anything along those lines. I have been a direct service provider, but that was more than 2 decades ago. So I think there are a couple other issues here. It's interesting to talk about the state and the prisons and the treatment that's available. I used to work for one of the primary, or I do work for who used to be one of the primary provider of substance use treatment services in the prisons. And I wrote those grants for years, or contracts, proposals. And it got to the point where the state cut the ability to fund those services. And when you're in jail, you're not eligible for Medicaid. And so the state has to fund those services. And so they made it in such a way that the provider effectively had to pay for the state to provide treatment services the way that the funding worked. And so it's an impossible situation. So the quality of the treatment, even that is happening at a very limited level, is very difficult to provide, and the effectiveness is very questionable, and it's miserable. The point that I think I want to really highlight that Thea just said is the primary provider of behavioral health care in the state of Alaska is the prison system. And that is just absolutely wrong. And I'm going to bring up a point. Anna and I met with the Anchorage legislative delegation, and I spoke to them about this, and I'm going to say it until it happens, is that back in the days before the trust was funded, we had forced everybody who experienced these kinds of issues into one place, Harborview facility down a little bit east of here, stolen from their families and forced in. And then we deinstitutionalized. And in the process, we created the trust to help fund the services. And that wasn't by choice, that was by force of law, which was a good decision by the courts. And then it was recreated because the legislature spent all that money in ways that were inappropriate and used the land in ways that were inappropriate. So then come to the year 2000, or just before 2000, it was API 2000, API replacement project, where the state made a promise. The promise was, we are going to right size API because API isn't the place where you want your ongoing care to be. It's the crisis response. So they made that argument, and they promised, we're going to cut the beds in half and we're going to implement community-based supports, which means funding. And they got the capital part right. They reduced API from 150 beds to 75 beds, which they sometimes have 75, but mostly they're operating around 40 or 30. and they never funded the community-based supports 20 some years ago. So what ended up happening with that system is that all of those people who were in care or able to get care in those 150 beds as they rotated through no longer could get the care, most of them, at least half. They ended up on our streets, untreated, uncared for. And that has been a growing problem since that time. So then we come to SB 91. The promise of SB 91 was we are going to take the people out of jail who need behavioral health care, who need these other things, who aren't dangerous, but who are nuisances to us and probably could be served in a less expensive level of care. And so the legislature, in all of its repetitive wisdom, closed the prison before they funded the community-based supports, and never did, in fact, fund the community-based supports, and then celebrated when crime went up because then they could say criminal justice reform was a failure. So twice in my span of living in Alaska, the state has made a promise to fund community-based supports and not funded it, which has driven hundreds of people into the streets with no care and no support. And so I made the pitch to the legislature, and I make it here, and I'll keep saying it. We need a campaign. The campaign needs to be fulfill the promise of those community-based supports, because until they do, this is what we're going to have, is people living in our streets and dying in our streets. And Anchorage can't afford to take on all of the problems of the state of Alaska. We do as much as we can, but we are simply not the state. And so I ask that we run a campaign at some point that is fulfill the promise of these community-based supports, because that's what's missing.
Well, I do think there is a lot of work happening. So, the whole Crisis Now framework, I know that to repeat, but, the whole way that it works is like for every 100 people that might call a crisis line, a proportion of them need somebody to come to them and help out. That's the mobile team. A small proportion of that are going to need to go to a facility for up to 24 hours for stabilization. And then a smaller proportion will need up to a week of care. And then after that is when you would go to API. So right now what we have is what Chris just described. You kind of launch from, I'm not able to function right now in my community or my home. Your main option is API or one of the DET units. So that's Matsu, Fairbanks, or Juneau. And those have been pretty constrained since COVID. So there isn't a whole lot in between, right? So the whole point of doing Crisis Now is we build out all these layers in between. And there's a lot, the work that you've funded here in Anchorage is awesome. Fairbanks is doing a really good job. Matsu, Juneau's getting started. Ketchikan's getting started. Kotzebue is getting started. So like what I see is it's a huge amount of work. Like HB 172, which was passed, that's a lot of work. It still needs work. There's funding gaps. There's all sorts of things. But the cool part is all around the state, people are understanding this framework and wanting to do it. I hear police, providers, ER physicians, everybody's like, yes, let's do it, right? So that's a great thing that we're building. And part of what the value of that is it helps to do kind of what this plan is describing. It helps to have a place where people come to when they're in crisis that is staffed by both medical and behavioral health, and that then can help that person connect to the resources that they need. So it provides a kind of coordinating function as well as a stabilization function. And then there's going to be more work to do, because just like you said, all the folks trying to do behavioral health in the community are underfunded and their workforce is really limited. And there's all that stuff too that we got to handle. But I guess it is, and I also want to say too, that API went from being in complete crisis, to doing really good work. They've got a really good team there now, and they're really working hard to address the things that sent them into crisis. And they are mostly keeping all their beds open. So that's a really bright light. And then I also want to say too, at DOC, we've got a commissioner there now who's been risen all the way through the ranks, and she has really good ideas. And then Travis Welch, who has been at the trust, just moved over to DOC. And there's other great people at DOC too. So I feel like it's a tough situation, but there's a lot of good work happening, a lot of good work, a lot of good people I think we have a lot of shared ideas now, which is different than when I think, 5 or 6 or 7 years back, we were a little bit more all over the place. Same things happened with homelessness. So just want to.
And happening.
Sure.
Just one note, then the word you use, coordination, is one that I have in my notes over here. You brought up the conversation about the muni has health powers, but the state has a role. There's one thing we really can't do is that statewide coordination. And the fact is the populations we're working with do move all over the state and have participation in community A, they're here, community B or C. And so there's one role we could never take on, which the state really has to do a better job with. And that is their role in coordinating the continuity of connection to these individuals we're talking about, which, the HMIS requirements by HUD and other behavioral health coordinating tools are good for that. But that's, I think, a differential that we don't have the ability to manage, that the state, we can't even try to get into that space very effectively. So, George.
Thank you, Chair. I wanted to just go back and say I appreciate, first of all, thank you for the presentation. Thank you to the members of the task force that participated in this as well. I appreciate the recommendations, and this has been a very fruitful conversation for me. But I wanted to go back to the very, very beginning, and I wanted to highlight that I appreciate the pivot to really healthcare and a health focused, and recognizing that maintaining housing becomes more difficult when we don't have untreated health, when we have untreated healthcare needs. So I just wanted to make sure that we heard that again and that the public hears that, and a couple of other points that stuck out to me that I wanted to shout out as well. The continuum of care. Thank you for bringing that back, and I hope that this body can continue to amplify that publicly and just continue to encourage the understanding and the public's perspective of the complexity behind all of these challenges, but also that there is a plan, there is a design, there is a framework of understanding, and that really requires to support the continuum of care, we need the continuity of investment at all the levels. And from that vantage point, I hope that we can move past the silver bullet methodology, the hopefulness behind division, that somehow the health needs of our community that impact the public sector in so many different ways becomes a partisan football versus healthcare and just practical, technical work that is required for our city to thrive and be healthy. So I hope that we can move in those directions. And the last point, I really appreciate the focus on the post-crisis network. I think that really speaks to the opportunity we have, and this is beyond the funding question, and so I understand the difficulties there, but the opportunity that I see to really engage our broadest level of the community with the perspective of silo busting as best as we can to make sure that there is no wrong door and there are pathways forward. So I just appreciate the focus from the task force bringing that, and the members of this body having this wonderful conversation today. Thank you.
Yeah, if I could just quickly respond. I think what you just shared actually does help describe how the state is trying to partner. I mean, I think there's a lot of good work happening at the state level too, not just with Crisis Now, but things like the Complex Care Initiative, which they're kind of incubating more internally right now, but I think the goal is to broaden that. And that's not the same as what we're talking about here, because they're talking about medical complexity and other things. It's broader than what we're talking about, but it includes this too. And then all of the work that's happening with Medicaid, there's tons of work still left to do, but the 1115, even though it's got difficulties and limitations, it did add services that we didn't have before. So, and a lot of them are these community-based services. So it's like the rollout is hard. It's hard to get the money to start the new services. Some of the rates are too low. Like there's all that stuff is still there, but at least we do have this framework now that we didn't have before. And I think as we work to implement all of that, we're starting to see, oh, well, this didn't really work out right, or here's a gap that we still have. And I think the state's really trying to respond to that too. So, and then just going back to that need for the kind of statewide coordination, that's just a real challenge here in Alaska. Like it really is. Like when I've worked in communities and regions all around the state, and the state also has a limited reach. We're such a big place. And when you get into rural regions, it's their tribal health organization that's the primary, and their tribal nonprofit that's the primary deliverer of services. The state piece of it is much smaller in a lot of places, and so we don't have a great way of saying like, okay, do we have one database that's got everyone in it? I always go back to Medicaid for that, because Medicaid probably is our biggest database. It's about 180,000 Alaskans are enrolled in Medicaid. So that's probably a really good place to start. But I think I just want to say that I think it kind of takes all of us, because we just don't live in a state where there is one entity, one ring that rules them all. Like that isn't where we're at. Like we're very, very overlapping jurisdiction everywhere,
Yes, and certainly Anchorage is the hub to the hub and
Yeah.
spoke model
Right.
with respect to this,
Yeah.
seeing all of the fronts and how we can play a role. Thank you.
Yeah. And making more hubs, I think, is a good goal, yeah.
So just your slide is next steps, but we didn't really come up with a set of concrete next steps. Are they in the report, or do you want to just lay out a kind of I saw your goals and outcomes, but I wonder what are the next steps that we should be working on?
Well, there's the priority action plan, which kind of tries to lay that out. And I think it's a little bit hard to know how to move forward without knowing who's the person at the muni or the team that's moving this forward. So, that can't be you guys, right? And I think there's a lot of folks ready to partner and work, but there has to be someone who's kind of like, the linchpin or a small team.
So
That would be
maybe
my
that's
first
the
step.
next step. For me, the next step is some kind of analysis of fiscal constraints, where the investments should go, so that we can identify where the money can come from and get to that part of it, because you can't have a department do stuff without a financial plan. But that's just me. Felix?
Yeah, thanks. So, I think several of us are continuing to work, whether that's with Director Rash or with the trust, or perhaps during the budget, on implementing those top 3 priority areas. But I do hear and understand your point of some kind of feasibility or economic analysis of what all of this may cost. And I think in the long term, because there are also a whole bunch of other different recommendations here that we didn't even talk about that I think are worth exploring. So what I have asked is the Health Policy Committee to maybe help be the steward of any future work outside of maybe the 3 top priority areas, which we're hoping to maybe get done quickly, of the future work to continue implementation of this plan, or report rather.
Okay, we have just a couple minutes left. Anyone? Any last words?
I'm just trying to think that through. There is, one thing that is ongoing right now that touches some of this is the crisis network. And there is a work group happening in Anchorage. My firm, Agnew Beck, is supporting that Anchorage work group. This goes beyond that, and it also is like a little bit more targeted, because we're focused here on people who are experiencing homelessness or at risk of, plus their complexity with their behavioral health. So it's definitely like a more targeted focus. I guess I'm just trying to brainstorm like where can it live, because it needs somebody to kind of push it along. So even if it's the Health Policy Committee, like who's pushing it along? Like,
Yeah, and I
don't
think
know.
that we need an appropriation and somebody to provide fiscal analysis that can give us the next steps. Otherwise,
But like
without,
for who? Like, is it for the health department? I just feel like it needs a home. I don't know. Yeah.
no, and I get that. I just don't know where it is implemented until we understand. But again, that we can chew on that.
Yeah, maybe it does. Maybe there's some kind of analysis that goes to the committee for you to.
That's like
Think
these,
about, yeah.
right?
Mhm.
We created a utility for stormwater and nothing happened. It doesn't exist yet, even though we have all the ongoing problems. right?
Mhm.
We did a financial analysis. The report was never delivered to us, but if we understood those impacts, we probably would have a stronger case
Mhm.
and how we could fund it. And
Mhm.
similar to this, I think
Mhm.
there's a financial piece that I have to reckon with as an appropriator. But we have exceeded our allotted time. We have 4 minutes to our next meeting. Thank you,
Thank
Ms.
you.
Thea, and we'll be adjourned for just a couple minutes.